Good evening, and I'm very happy to be with you all. I want to first thank Dr. Mehta and Arkush for their incredible presentations, and they've spoke mainly about pregnant people and women in the general population, and I'm going to be talking about women who are engaged in treatment for substance use disorder. So just a little description of the maternal addiction treatment education and research program at Jefferson. We're a 50-year-old program that has been serving women and pregnant people here at Jefferson. It was begun by Loretta Finnegan. Many of you as physicians may know the Finnegan score. That's how we screen for babies and neonatal abstinence syndrome when they've been exposed to opioids in utero. We have a comprehensive treatment program. We generally serve about 300 to 400 women a year with an ongoing population, about 250 women who come daily, 7 days a week to our clinic for medication and therapy. And we have therapists doing individual and group therapy, mindfulness-based parenting, medication. We have pediatric care on site in a group pediatric care model. We have centering pregnancy for prenatal care on site and psychiatry. We have 2 child care centers, one in our outpatient and one in our residential program. And we offer parent counseling and support, child care services, and legal and housing advocacy as well. Transportation and more recently food and academic support is also provided to women as part of their treatment program. And there are really 2 main barriers to recovery, and one is poverty. Poverty is probably the largest factor, and the other is stigma. Stigma from the family, from medical professionals, and from the courts. And so when I say stigma, the reason why I bring this up in a little bit more detail is what comes to mind when you picture a pregnant woman and somebody says, this woman is addicted to drugs. There are a lot of negative associations about the woman and her condition. And so this is where the stigma, in part where the stigma comes from. The other part is that we are the only developed nation that treats substance use as a criminal issue rather than as a medical or health issue. So what are the assumptions here? So the assumptions of my presentation are, we can decrease and prevent intergenerational trauma by supporting the maternal infant dyad. And we've done all of this. This is all done through research, or our research on maternal, mindfulness and mindful-based parenting has shown significant increases in the quality of parenting among our women in our study that actually went above the normative quality in the United States. Women in treatment for substance use, some other assumptions are that prior to pregnancy, they have little access to healthcare, no insurance typically until they're pregnant. So there's no preconceptual health, as we like to think about it. There's no decisions around pregnancy or around reproductive contraception. Pregnancy for a lot of these women become an active decision to battle addiction. And so the majority of the women that we serve, almost nearly all of the 400 we see a year, come directly from the hospital, because when they find out they're pregnant, they go to Jefferson. It's well known throughout the state of Pennsylvania and New Jersey and Delaware as well, that if a woman can get themselves into Jefferson, they can be stabilized off an opioid and on to methadone or buprenorphine. So it's a very active decision to be in this battle against addiction. There's a strong desire to become a good mother, a good parent. And using opioids is numbing rather than getting high. And I think that's important, and you'll see why in a bit. But issues affecting parenting among mothers with SUD are affected by this intersectionality of poverty and drug use. We need to think about the political, historical, sociological, and the economic intersectionality and the context of intergenerational trauma, which bring women to the point where they have a substance use disorder. And I would say that from the 1980s, we've seen a shrinking economy, a deepening of poverty in America, and certainly a wider disparity. And during this same period of time, we've also seen greater family isolation with fewer extended families, a lack of community participation in raising children, and parents needing to work longer, many more jobs outside the home. Additionally, what we lost is the destruction of the Great Society and the war on poverty, which these federal programs that were enacted through Presidents Kennedy and Johnson really provided a social safety net that went beyond the net to actually lifting working class into middle class. And with those programs gone, we see more and more people who are or undereducated, lack skills, and are not as employable. Also, during this period of time, we know that there have been more adverse exposures to children as a result of the poverty and isolation. I'll share with you what it looks like in my population. All of this leading to higher rates of drug use, because also during this time, we have greater direct marketing and distribution of pharmaceuticals to the public. So with this in mind, that there are complex and cumulative effects of poverty, isolation, stigma, and the discrimination that accompanies stigma, and all of that impact recovery. So this is a sample of women we looked at in our mindful-based parenting study, and it shows that the majority of women who have substance abuse are white. And what we're seeing is more non-white and African-American women. When I first started this work about 8 years ago, it was more like 85 to 90% white. But the issue of stimulant and opioid use disorder is moving into communities of color, and we're doing a little bit better of a job going into communities that are underserved. You can see, my slide got a little bit kind of mixed up here, but the numbers are correct. It's split education-wide, about a third for less than high school, and more than high school. And recently, we've been seeing more professional and graduate educated women coming into treatment. Primarily, women are about 95% ultimately in this study were unmarried, although 60% have a partner. And you can see their unemployed is 90%. Generally, women come into treatment with 2 to 3 children, and this has gone down because about 8 years ago, it was around 4 children or more was really what we were seeing as the median. And how many months are they in treatment by the time we did the parenting study was about 1.5 years into treatment. And if you look at their adverse childhood experiences, what you see in this dark blue range, 57% is 4 or more, And what we learned from Folletti's research on ACEs is that if people have 4 or more ACEs, it's predictive of behavioral health issues and substance use disorder. And when they have 6 or more, which some of these women do, there's actually a 20-year life loss amongst people who have 6 or more ACEs. And this is an older slide, but it still holds true today. You could see the green side is our population in my particular study that I was doing, and it reflects the population in the city as well, that the ACEs are much higher in this population than they are in the population country or in Philadelphia with 4 or more ACEs. So we do a lot of research on mindfulness. We do many other studies, but we do research on mindfulness. And I think this is really important, especially with the stigma issue, is having women learn to be in the moment and let go of their stories and their victimization as a way for them to hold on to the difficult work they need to do in recovery. What we're finding is that mindfulness leads to this being able to notice in the moment. And if women can notice what they're feeling, they're less reactive, and therefore they can think about relapse, think about and make better choices in terms of staying in recovery. This is mindfulness leads to greater amounts of compassion. And it's a trauma responsive method for women. And then this slide talks a little bit about the work we're doing with physicians as well, where we're talking about self-compassion and versus self-care, like a more meaningful caring about yourself with compassion. And just to show you that all of the work that we're doing, this is just one of the faculty here, and that I just took a snippet from her CV. There are 4 faculty here, and all of the work that we're doing, the research, so that what we actually implement is evidence-based. And mindfulness-based parenting, the city just recognized, Philadelphia just recognized mindful-based parenting as an evidence-based program that is actually billable to Medicaid for, because it has such an impact on the women. And just say a couple of things about women in this work that we're doing is that, that women come in with this is called Mindful Dialogue for Life. It's a process we do here at Mater with our staff, and what staff felt this is a slide that shows what staff felt during COVID, so worried about the women when they couldn't come in for their treatment. And there was a lot of fear over overdose and suicide and the loss of infants. And they have a right to be fearful, as Dr. Mata has explained to us. There's a lot of life loss in this population, but there are also some good stories. So I'm going to end with one good story. We have 3 of our staff, our former clients of Mater, and one is a manager at this point. She's had, I think this is her 4th promotion. She'll be a project manager of the Mater Academy, which is to help women move towards financial independence. And we hope to hire 6 people in this new grant, all with lived experience, because they have the most wisdom and the most to share with all of us. But these are women who, all the women here, if you ever want to come to Mater for a visit, hopefully after COVID, you'll see moms and their babies, and a lot of love and a lot of caring. So thank you.